Hello, I'm Dr. Daniel Griffin.
I'm Dixon DePommier.
And today we're going to be discussing musculoskeletal and neuropathic pain.
Oof.
It's quite a broad topic.
It certainly is.
I
something that we've all had, I presume. Also.
Was that a sigh? What was that noise?
A little bit.
Were you in pain?
Well, in my youth, I was involved in athletics, and I've had my share of lumps and bumps like everybody else. Mm-hmm. But I've never had chronic, long-term skeletal muscular pain or any neuropathies that I couldn't deal with. But I presume that we're going to discuss those now.
I'm glad you sighed because this is a broad topic. And I'll say as broad as fever. This is one of the common complaints where people will come to the clinician and they will present with musculoskeletal pain. And then similar to fever, we're going to be trying to figure out, is this benign musculoskeletal pain,
right,
which is really what we're going to end up focusing on eventually, or is this a warning sign of something more serious?
Sure.
Something that maybe we'll be covering in one of our other chapters or other lectures.
Yep.
So just to start off, when we say musculoskeletal pain, what are we talking about? So,
exactly. I was about to ask that, actually.
Go ahead and ask.
Daniel, I'm sorry, Dr. Griffin. Just what is meant by musculoskeletal pain?
Yeah, it's really if you break it apart. My dad does this with, just think about what the Hebrew means. I'm like, I don't know what the Hebrew means. But musculoskeletal, it's pain that is either focused on the muscles, so muscular pain,
sure,
or pain that's skeletal pain. And in a lot of ways that might be joint pain, but it also might be pain coming from a vertebrae or a broken bone or...
Yeah. Are we talking about bruises and trauma injuries that could occur throughout the body as a result of an accident or some occupational repetitive motion type of thing that people go through?
So certainly that would fall under this. And a lot of times people will present to the clinician with, we'll say, osteoarthritis, arthritic pain, where
yes.
I've been having pain
yes.
for a long period of time in my joints.
Yep.
Or they might say, I've been involved in a recent fall or an accident, and after that I
sure.
have this pain.
Sure.
A lot of the pain is due to repetitive tasks. So you have to sit in a certain way,
right.
you have to work in the field, you have to be bending over,
exactly.
and you may be developing pain. So we have our arthritic pain, which
yep.
may be chronic.
Yep.
We can have some injury or acute movement pain that can be related to a fall, an injury, a task. And then, unfortunately, in a lot of these situations, we can have pain that becomes chronic. And then we'll touch a little bit as we move on. In addition to musculoskeletal pain, we're going to be talking about neuropathic pain. And it's important for us to distinguish musculoskeletal pain, which is treated and considered one way, to neuropathic pain, which is treated another way.
Sure. Great. Okay.
And I know you asked me before about neuropathic pain, and we talked a little bit about...
Yeah, I'm curious as to the relationship, because I know that you can't move without some nervous stimulation to the muscle, which is, of course, attached by a ligament to the bone. So you've got the whole system working the moment you take a step or the moment that you reach for something. So how would you distinguish between neuromuscular, or rather, I'm sorry, not neuromuscular, musculoskeletal pain and neuropathies, which might be due to a movement of a muscle that's injured?
True. And the neuropathy is broad. It can be a neuropathy, can be an issue with a nerve giving you motor. It can be an issue with a nerve giving you sensation, or as we're talking about, it could be a nerve delivering pain.
Right.
And one of the very common, unfortunately, growing problems throughout the world is diabetes-associated neuropathic pain, where people have the feet are burning, and it's just this really difficult pain to live with.
Wow.
So one of the things that I like to ask people when they first come in,
yep.
when they say that they have pain,
yes.
is what is the severity of this pain?
Okay.
And I don't know if you're familiar with some of our severity scoring systems.
No, but I have a feeling I'm about to become familiar with them.
Okay. Well, for those of you that are being introduced to the pain scales, this will be coming up on the screen now. For those of you who are watching the videos, but for those of you who are listening to our audio version, I'm going to be going through with Dixon here about the different pain scales. And one of the common pain scales is a numeric pain scale,
Okay.
where we grade pain from 0, meaning no pain,
Right.
all the way up to 10, which is incapacitating. And the grades actually go 0 being none, 1 would be minimal, 2 mild, 3 uncomfortable, 4 moderate, 5 distracting, 6 is when you start to be distressed by the pain, 7 is when it's starting to become unmanageable, 8 is intense, 9 is severe, and 10 is when the pain incapacitates you.
Right. Yeah, unfortunately, I've lived long enough to have visit the hospital with relatives and friends of mine who were incapacitated because of some serious illness, and they were on pain medications. And the nurse would come in and ask them how they felt, and they would say, "I'm in pain," and they would increase the dosage of whatever they were using as a painkiller, like morphine or something of that sort. And she would then ask, or he would then ask, "Well, how do you feel now?" Mm-hmm. And almost immediately, the pain level drops, of course, when you increase the dose. So, but I've never heard them say, "Is it from 1 to 10? How do you feel?"
Yeah,
I haven't heard that, and you know, I've seen it on TV, of course, but you ask that regularly. Is that true?
You know, it is in many ways become the 5th vital sign. And it was mandated because, at least in the United States about 20 years ago, there was an epidemic of undertreating pain.
Right.
This was then followed by an epidemic of over-treating pain.
Of course.
And it becomes really challenging to interpret this. We have our numbers, we have our words, and actually for the younger individuals or for illiterate individuals, we'll actually have pictures, and it's facial expressions.
Oh, yeah.
Just, you know, when someone is incapacitated, they'll often be red in the face, they'll be crying, they'll be clenching of the teeth.
Got it.
Someone who is, you know, watching the television, as
Yes.
you may be getting your medical information that way, they might be they might tell me they have 4 out of 10 pain, but yet they really would like me to come back when their show finishes.
Right.
So but the numbers can be challenging because,
Sure.
as you mentioned, this is the first time you're being introduced to them. And can you imagine a patient comes to see you as a doctor and you say, "Oh, what level is your pain
Right.
on a scale of 0 to 10? They may throw out a number, and then I often ask, "Okay, so you said 7. When in your life have you had a 7? When have you had more or less?" And I try to put that level of pain in context.
Right.
And I'll tell a couple anecdotes here.
Please do.
And actually, the anecdote centered around a patient I saw earlier this week, and she was in pain, and she told me that her pain was 7 out of 10. So I said to the woman that I once had a patient when I was working out in the Veterans Hospital in Salt Lake City, Utah. And this individual was in the intensive care unit, and I went over and they were focused. They had a little bit of sweat on their upper brow. Their heart rate was increased. They looked uncomfortable, to put it mildly. And when I asked them, "How much pain are you in?" The man continued to look straight ahead and said, "It's only about 4 out of 10, doc." And I said, "You know, you look a bit uncomfortable for a 4 out of 10 rating.
Sure.
Have you ever been in this much pain before?"
Right.
And his response was that, "I was gut shot in battle in Vietnam, and that was not as bad as this." And so his 4, as you can imagine, is quite different than...
Maybe he thought the scales were the other way. 1 is the worst you can ever have.
Oh no, his expression was, "I could imagine much worse pain."
Oh my goodness.
And in his world experience,
Wow.
you know, the 3, the 4, he had seen people go through quite significant
Right.
battlefield trauma.
Right.
And so the woman who said it was 7 out of 10, I asked her, and she said, "Well, when I was in labor, it was not as bad as the pain I'm now having."
My goodness.
So again, her 7, which people might use on our scale, say, "Well, it's getting to the point where I really can't manage." She probably should have been saying an 8 or a 9. If the pain was beyond what she experienced in labor, it was probably... So I always say these number systems are great, helpful,
Right.
but you need to put them into context.
So the other thing that I guess everybody would be asking at this point then is, what brought that patient to your attention? Did
So
they
that-
come
yeah.
in because of the pain, or were they also suffering from something else? And as you're interviewing them, they say, "Oh, by the way, I've got chronic pain," or something like that.
So I think there's two situations where that can happen. Often they come in for something else, and as you're going through the list, and by the way,
Yes.
in addition to why I came in, this back pain is just getting unmanageable,
Right,
and can we talk about that too?
Right.
It's actually one of the common complaints as presenting. It's one of the most common reasons they come to see the clinician. And so let's talk. We've gotten a sense of severity,
Yep.
and now we're going to talk a little bit about understanding the pain. And so I think what you brought up was nice. Is one of the next questions we ask once we have severity is, tell me a little more about the pain.
Where does it hurt?
So that's perfect. Where is one of the most important guiding bits of information.
I'm sure.
Is the pain in your toe?
Right.
Is the pain in your back?
Right.
Is the pain in your head?
Yeah.
They may eventually lead us into a headache differential. They may lead us into some other differential based upon the localization. So that's one of the first things in the diagnosis is severity. Second thing might be localization. And then, like so many things in medicine, we might ask, when did it start? Duration.
Sure.
Is there anything you can think of that may have happened before the pain that may have brought this on? Anything you do to make it better? This reminds me of when I was graduating medical school, Eli Wiesel, who wrote the book Night, gave us a bit of a graduation speech, which I remember to this day.
Wow.
And he said, as much as you think you know, the patients may know more, so always ask them.
Absolutely.
So really critical in musculoskeletal and neuropathic pain, which we may see as benign most of the time, is taking the time to listen to get all this information.
Sure.
How severe is it?
That's right.
When did it start?
Yeah.
What makes it better? What makes it worse? And then any associated symptoms.
Yeah.
If someone has back pain and fever, if someone has back pain and weakness in the limb, if someone has back pain and problems with inability to urinate. So you're starting as you're going through this to try to make a distinction between benign pain that we're going to address symptomatically, much like fever, and more serious pain that will take us down different algorithms.
Great.
So the diagnosis, in addition to symptoms, then we'll move on to signs. Someone who has what you feel is benign, potentially benign musculoskeletal exam, I always recommend that everyone gets a complete physical examination because you do not want to miss something serious.
It's true.
And unless you get in a routine of being thorough, this is where you're going to miss something.
Yeah.
And that'll be embarrassing for you and potentially devastating for the patients.
So, do you actually ask them to get up and walk around so you can see whether or not they're avoiding pain by altering the way they move?
I like to say my physical exam starts before they come into the exam room, and I'm watching them walk in.
Okay.
I'm watching how they sit down. I'm also watching how they get up. Do they need to use the arms to push themselves up? Are they able to just stand up? Do they sit down gingerly?
Right.
So the whole exam starts before I might bring them over with my stethoscope and my tools of the trade.
Right.
No, that's excellent question. You also, when you're looking and focusing on a particular, you might look for any degree of deformity. I'm always amazed that people are willing to tolerate quite a bit of.
And then there are some diseases, and I know them because I used to teach some of them, not all of them, where there's no pain at all, but you take a look and you say, you mean to tell me that that doesn't hurt? And so that's the opposite of what we're talking about, but it's pretty important to bring that in. I'm thinking of diseases like leprosy or elephantiasis or something of that nature, or leishmaniasis even, where the lesions are fulminating and they look violaceous and they look infected, and they are, of course, but it doesn't result in pain. So how does that work?
Yeah.
And is that an organism characteristic, or is that a defense mechanism to keep the body working so that you can drink and eat and walk and that sort of thing.
Well, I would say that's an interesting issue, and I like the fact that you bring up leishmaniasis and leprosy. Certain diseases, what is striking is the absence of pain.
Exactly.
So a person will have an area where they notice, I can't feel, and the inability to feel in a certain patch might be as disturbing as
What
the
is
pain.
that called clinically when you find an area that doesn't respond to
Anesthesia.
Aha.
Anesthesia. So in addition to pain, as you brought up, lack of the ability to sense something can be an issue.
Right.
We'll just review our warning signs. So the warning signs that make you say this might not be benign are associated symptoms such as fever,
Yep.
weight loss,
Right.
impacts on bowel and bladder function, ability to urinate, associated sensory loss. And now that and we're going to have to spend a little time on treatment here, and I say a little, not a lot. Once we've ruled out something more serious,
Yeah.
and we want to provide symptomatic therapy, much like fever, I want to make a point of we don't want to jump straight to pharmaceuticals. Because a lot of these areas you go in, if someone comes in and they say, I work in the fields, my back is always killing me,
Right.
what are you going to give them? A week of medicines, 2 weeks of medicines?
A paid vacation.
Yeah, paid vacation. I want you to stop working and feeding your family.
Yeah, exactly right.
So interesting enough, one of the wonderful experiences I had once on a trip down in Central America is I was with a physical therapist, and this individual would be teaching the different individuals exercises, ways of lifting, the posturally appropriate way. So first thing I guess I will say is always focus on what's precipitating it when possible, and these are inexpensive interventions, exercises, stretches, non-pharmacological therapy, and a big thing I will say, fluid intake. In many parts of the world, people are not getting adequate fluid, and a lot of things, aches and pains, headaches, adequate fluid intake can really make a difference.
So what do you do to detect dehydration?
We're going to have a whole section, I think, where we talk about that.
All right.
But I'll say in most cases it's the rule rather than the exception, dehydration.
Okay.
And because of that, we're going to be a little more careful in the type of medicines we use.
Yeah.
In developed countries, we might use a lot of ibuprofen. We might use a lot of what we call non-steroidal anti-inflammatory medicines or aspirin.
Yeah.
And someone who's dehydrated, you're running a lot more risks. So you really want to relegate those to second line and use more of your paracetamol. And we'll have a chart for those of you watching with the different doses. But for the younger individuals, they'll be weight-based. And as you get to adults, you'll use higher doses. But the distinction that we'll go back to that we first talked about is neuropathic pain does not respond particularly well to either one of those therapies. And in many parts of the world, a medicine, amitriptyline, usually started at low dose before bed, can make quite a difference.
Wow. Do we have access to that drug in this country?
So we do. Yes.
Amitriptyline. I don't think I've ever heard that one.
I believe Elavil is the brand name, so maybe you remember it from that.
All right.
But yeah. So I think we've gotten mostly through a pretty complicated subject here.
Well,
at least on a very basic introductory level.
You haven't covered 8 through 10 though, because 8 through 10 is really almost an intravenous clinical intervention strategy.
Now that's perfect that you do that, because that's something that I think we need to circle back to in every of our lectures that we do. Is there will be situations that are going to go beyond the means of a lot of at a lot of clinics.
Yes.
And we don't want to throw up our hands and say, well, we've done all we could do. Well, that's fine. We may have done all we could do, but there's certain levels of pain that really are medical emergencies and require opioids, require much stronger pain medications.
Exactly.
And this is one of the reasons I think people go into medicine. They don't want people to suffer.
Right.
And this might be a situation, you can think of trauma, you can think of vehicle accidents, you can think of cancer, the list is quite long, where they'll have intense, severe, incapacitating pain, and our armamentarium of acetaminophen, of Aleve, of ibuprofen, of naproxen are not going to really cover this. And you're going to need to either have the access to opioids or have the ability to send someone to a facility that has that.
So you and I have similar travel experiences for different reasons. Mostly mine are vacations, and yours are mostly clinical intervention strategies. But we've both been to places where people who live at high altitude, particularly Peru and Chile and the Himalayas, where maybe not so much in the Himalayas, but certainly in South America, they have access to coca leaves. And they're using coca leaves to chew and to derive the cocaine from it to relieve the altitude sickness that is often experienced at altitudes above 18,000 feet, let's say. And so there are lots of folk-oriented medicines which have as their modern equivalents the opioids that we currently use in, let's say, Western medicine. I'm often reminded of the stories that I was told when I was in school about the use of cocaine by farmers to relieve everyday pain at the end of a very, very difficult time during the summer months. And the derivative of that, which we now call Coca-Cola. And it used to have cocaine actually in that fluid. And of course it's not there anymore, but the coca part of Coca-Cola refers back to that origin. And that was a common drink back at the turn of the century.
Yeah. No, many areas where people will practice, there'll be local remedies that might be plant-based. And a lot of those are quite efficacious. And a lot of times while you're there providing care, you might also be learning about some of the remedies which have yet to be spread to other areas.
And aspirin is another one, but we won't go into that.
All right. All right. Well, thank you for joining us again today.
It's a pleasure.
And we look forward to spending more time with you in the future.
Yep.